Hey everybody, Will and Kristen Flannery here, better known as the Glaucomfleckens. In honor of Pain Awareness Month, we're excited to do a special cross-promotion with one of our favorite podcasts, Bendy Bodies, with Dr. Linda Bluestein.
Linda is an anesthesiologist, an author, a podcaster, obviously, and a wellness advocate who brings her professional expertise as well as her personal experience with hypermobility, which I also have a
Yeah,
personal
you know a
experience
thing or
with.
two about that.
Yes, she brings that to her audience in a way that's really grounded, relatable, and accessible, even if you don't work in medicine like I do not.
And she does, thoughtful interviews, deep dives, and just shines a light on the challenges that people with connective tissue disorders face. And there are a lot of challenges that they have to
Yes.
go through, and just helps patients with a variety of different problems, including chronic pain. And so we are proud to be doing this collaboration and sharing a favorite episode from each other's feeds.
Yeah.
So she's going to share one of ours.
Yeah.
We're going to share one of hers. Today, we're doing this interview, a recent interview with Dr. Zach Spiritos, a neurogastroenterologist. It's very specialized.
Yeah.
About why some GI problems can be so difficult to detect with standard testing and how that impacts patients living with hypermobility and chronic pain.
If you like what you hear, be sure to check out more episodes of Bendy Bodies with Dr. Linda Bluestein wherever you get your podcast or check it out on YouTube. And we will include a link in the description too.
That's right. We hope you enjoy this conversation as much as we did and look forward to hearing what you think. Enjoy.
I don't empirically put people on a gluten-free diet, although I'm hearing more and more that maybe I should. You don't want to overly restrict people. When there's not a lot of data to support that it helps a lot of folks, it certainly helps some people, but not everybody. So that's where I think keeping a very detailed symptom diary is really helpful, along with a food diary to understand what your triggers are.
Welcome back, every Bendy Body, to the Bendy Bodies podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. Today, we'll be talking with Dr. Zachary Spiritos, who is a neurogastroenterologist. I'm really excited about this conversation because I have had lifelong gastrointestinal problems. Now, I have not really been having any recently, knock on wood, but when I was a child, I had lots of problems. And when I was in my residency at the Mayo Clinic, I would get such severe episodic abdominal pain. They were working me up for all kinds of bizarre things, including porphyria. Later, of course, I had an irritable bowel diagnosis. And after I had my two children, my lower esophageal sphincter just decided to give way one day, and I started having horrible, horrible reflux and ended up having a surgery called a Nissen fundoplication, and that's where they wrap the top part of your stomach around the bottom part of your esophagus so that you don't get that reflux anymore. So my Nissen fundoplication has opened a little bit because I vomited a number of times. But anyway, this is about you, not me, but I just wanted to share that I've had lots and lots of GI issues as well. So Dr. Zachary Spiritos is a neurogastroenterologist and founder of Ever Better Medicine, a specialty clinic focusing on treating complex digestive conditions, dysautonomia, including POTS, and mast cell activation syndrome. He trained at Duke for gastroenterology and now works with patients who often have overlapping conditions such as disorders of the brain-gut interaction, EDS, MCAS, and dysautonomia. His approach combines conventional care with a strong focus on lifestyle, nutrition, and patient education. I am so excited to have this conversation because I know that you are so likely to have gastrointestinal concerns. This is such a common thing that I see in my practice, so I think this is going to be a really important episode. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Okay, I am here with Dr. Zach Spiritos. Did I pronounce that right? I should have asked you before we started.
You nailed it.
Okay,
It's a coin toss whether people get it right, but you got it.
Okay. I have to tell you, we got over 200 questions when I asked on Instagram what people wanted to know from you. I could not believe it. I was blown away by the number of questions that I got. And so we have a lot to cover today. In fact, I want to tell you some of the things that, just to give you a little bit of a heads up. Okay, we're going to talk about motility, dumping syndrome, gastroparesis, which of course is a motility problem, SIBO, visceral hypersensitivity, leaky gut, gluten intolerance, POTS, visceroptosis, compression syndromes, microbiome problems, malabsorption, inflammatory bowel disease, pelvic floor dysfunction, and of course, treatment and diagnosis. We're not going to get to all of this, obviously, but I'm just trying to give you the
Is that
big,
it? There's nothing
yeah,
more?
yeah. I'm trying to give you the big picture of what people asked about. So tons and tons of questions. Of course, lots of questions on medications and diet and all kinds of things. But I have to tell you the really funny thing first before we even launch into this. Somebody actually put in the questions, is he a real doctor? He's too photogenic and great in front of the camera. Seems sus.
Oh boy. All right.
So I just had to
Yeah, I
mention
mean, these
that.
degrees you can get from Kinko's. Like you can really just you can do amazing things in Photoshop. So
Exactly. So this is going to be such a great conversation. I know you've been doing such fabulous work in social media, really trying to raise awareness, which is really, really wonderful because we know that so many people are getting gaslit and they're just not getting the care that they need. So this is so important. So thank you so much for joining me today.
I'm such a big fan of yours that this is I just started the social media journey last year, and I've been listening to you for. I mean, this is how I started to learn about hypermobility when I saw it in the clinical. This is you provide such great, I guess, um, digestible information about how these patients present and talk about the challenges that they face and how to deal with them and kind of hooking me up with other experts in the field so I can reach out to them. Like I think I told you about Dr. Hansen before, the slipping rib patient, and just you've helped me make sense of this patient population that is now my entire clinic. And so you've been my mentor from afar, even though you have no idea who I was until a couple weeks ago. So I'm grateful for you and I'm happy to be here.
Oh, well, thank you. That's great. I mean, that's the whole goal is to have as many, patients, of course, get as much information as they need. But also, I love hearing from physicians that have stories like that because you obviously are helping a lot of patients. So it has such a bigger, butterfly effect when we can, really help with physician education like that. So how did you get interested in this population of people?
Well, I'm a neurogastroenterologist by training, so I went to Duke. And early on in my attending career, so I've been out of fellowship training for about 5 years.
Hmm.
I did a lot of DGBIs, which are disorders of the brain-gut interaction. So
Mm,
IBS, gastroparesis, functional dyspepsia, visceral hypersensitivity, pelvic floor dysfunction. And then as I kind of grew my practice, I realized I was inheriting a lot of patients with dysautonomia and hypermobility, but I didn't know a lot about it. This is a couple years ago. And then we'd work on the bowel issues and their GI sensations and all of that. But then and we were making progress there, but then people still couldn't stand up.
mm,
And they'd have all these complaints that I couldn't figure out. And their PCPs didn't have any idea either. So I just started to look things up. And, I'd try to send patients to the local POTS cardiologist, but he was booked out for centuries. And that's at UNC, and the Duke cardiologist is booked out centuries. So I'm pretty savvy at cardiology. I went to a residency program with Dr. Cutchins,
mm,
who's amazing, and at Emory, and they train you to be effectively a de facto cardiologist. So I was like, I can do
mm,
this. And so I read and I read and I read, and I spoke to a lot of people and have amazing mentors in the field. And so I started to treat dysautonomia.
mm.
And in that, I started to acknowledge a lot of the challenges that people with um, hypermobility face as well. So I diagnosed occult tethered cord and craniocervical instability and slipping rib, and obviously there's the malls and the vascular compression. So once you start learning about these things, these patients start to make a lot more sense, and then
Mhm.
you start introducing yourself to the wild world of MCAS because that plays a big factor in all this pathophysiology. So that just adds another wrinkle to everything. But so it's been a learning process, and it was just a natural progression of I think my neurogastroenterology um, uh, kind of path and the patients that I see.
Yeah, and that's so fascinating because I think, maybe we have heard about the connection between the nervous system and the digestive system, but it sounds like it's much more extensive than most of us realize. And treating the gut requires often more than just medications.
Absolutely, absolutely. Especially, there's when patients come to clinic with whatever GI problem, and the first kind of the kind of the price of admission is usually an endoscopy or imaging of some sort. And when all the tests come back normal and the hardware stuff is normal, so there's no cancer or Crohn's disease or peptic ulcer disease or H. pylori, then you enter the neuro GI world. And that's where, there is some disconnect between how the gut, the immune system, and the brain are communicating. So, our gut sends signals to our brain via our spinal cord, and then the brain receives those signals and then propagates signals back to our gut, informing how it moves. And so if there's any disruption there, you can have not only disturbed sensation, like heightened pain, but also altered motility as well.
Mm.
So you got to connect, you got to, get a focus on the gut, the central nervous system, and there's a lot of different ways to do that. But it can be tricky.
Yeah. Oh, definitely. Definitely. And so let's start by talking about this population of people. Like you said, you already mentioned dysautonomia, and one of the types of dysautonomia, of course, is POTS, or postural orthostatic tachycardia syndrome. And we know that people with EDS, like you said, often have mast cell activation disorders, or mast cell activation syndrome, sometimes mastocytosis even. So let's talk about what are some of the most common gastrointestinal problems that this population faces. And, I'm sure we could talk about this for 20 hours or more. So if you could give us kind of a rundown of some of the most common things that you see.
Yeah. Slow motility and pain, for sure. I kind of kept it broad because there's so many different ways in which this can play out. But I think we could start with the slow motility first.
Okay.
So with dysautonomia, right? It's an imbalance in your parasympathetic and your sympathetic nervous systems. And so you're more driven towards the sympathetic line of things, and your parasympathetic is a little bit more dampened for a variety of reasons. And when we're in our parasympathetic nervous system is rest and digest. It helps your stomach squeeze and your sphincters relax, and to push that food distally to where it ultimately reaches the rectum, and then your anal sphincter relaxes and you can defecate. But when you're kind of more in that sympathetic kind of drive, things don't move as well. And so you can develop slow motility. So gastroparesis. Well, let's start more proximally. Ineffective esophageal motility of the esophagus. So when we read manometry studies, we can often see that where the esophagus just doesn't squeeze as well as it should. Gastroparesis, small bowel dysmotility, which we have a tough time measuring. There's certainly tools to do so, but I don't do that in my practice. And then, a colonic inertia, or slow moving colon. And there's defecatory dysfunctions, which is kind of a different animal altogether, but pelvic floor dysfunction, which we often see in hypermobility. And then pain. And so when we talk about dysautonomia, right, let me talk really quickly about the hypermobility folks. So they also have a relative neuropathy as well. Not quite sure why it happens. Maybe I could pick your brain about that. And how I make sense of it is the kind of the disrupted collagen in turn, you get more lax tissue and that disrupts the nerve endings, but you can get this relative neuropathy. So they also are suffering from a type of dysautonomia, even if they don't have full on POTS. And then let's talk about pain. Okay, so when we talk about dysautonomia, right? So the vagus nerve conveys our parasympathetic, kind of afferent and efferent nerves. So our afferent nerves take signals from the gut to the central nervous system, and the efferent nerves take signals from our brain to our intestines. And so there's not only issues with movement, right? So where the brain sends efferent signals to the gut in terms of how to move, but also the afferent signals are perturbed as well. So there's a disruption in pain signaling. So you have intense nociception, so more pain than you should, which we often we call hypersensitivity. So in gastroparetics, right, they sometimes get a lot of pain. But that pain is unique in the sense that you can give them promotility agents that help the stomach move and squeeze, and that should make their pain better, but it doesn't. So you give these patients promotility agents, right? And you can document that the stomach is squeezing better on imaging, but their pain is still there, right? So it's more nuanced than just getting things to move. There's also a pain sensory disorder as well. You also have to be aware of everything else that can uniquely affect this patient population. So MCAS can cause a lot of GI pain as well. So you have to tease out whether there's a mast cell disorder at play, because those mast cells really can hypersensitize these nerves. So they can, when they live in the GI tract as well as like everywhere else in the frickin' body, and they release not only histamine, which can sensitize nerves, but TNF, so pro-inflammatory markers that can cause local inflammation and really sensitize those nerves. So that can cause pain. And then, so the patients who have, pain with gastroparesis, you're like, well, do they also have malls? That's also, you get postprandial pain. So you just have to be aware of these things. All these conditions, have different ways in which they present. So there's certain questions that you can use to tease it out. But really, it's, a little bit's trial and error. We try certain things, we obtain some diagnostic data points, and then we touch base. Like every week, I touch base with patients every 7 to 10 days to be like, is this working? Because that's also informative in terms of what the underlying pathophysiology may be. I know that was pretty long-winded, but hopefully that was
No, no,
succinct
no,
and
no.
to the point.
Yeah, no, and it's a good way to kind of, think about things in a putting them into kind of some bigger buckets, if you will. And so I really like that. So that's really interesting. The visceral hypersensitivity problem, I was scoped, and I've had a lot of GI problems throughout my life. Knock on wood, not now, but I have had in the past. And I think it's really tough when you get told, well, you have visceral hypersensitivity, because a lot of us, we gaslight ourselves as well as other people gaslighting us, and even if it's explained to us that, no, this is a real phenomenon, we tend to think, oh, I'm just not strong enough, or I'm just not able to cope with this adequately. So I feel like there's a lot of misunderstanding around that, and that it's very challenging for people to deal with that as a diagnosis. I feel like there's certain diagnoses that are a lot easier for people to accept and wrap their heads around. And maybe part of it is because it's easier for their families. And, if they go to another physician and they say, oh, well, I have, this particular thing that can be measured, that they tend to get more respect for that.
Yeah. I mean, we could measure it if we did functional MRIs. Like you can really
Mm.
pick this up on, we don't do them because they cost an arm and a leg and they don't really change treatments. But, it is really challenging. And then I think it's compounded when I think a lot of providers don't know how to explain it. And so
Mhm.
they're like, it's, if you just take a load off, just de-stress a little bit.
Right.
And that's problematic for a couple of reasons. One, it oversimplifies the problem because it is, and it's multifactorial. If you're doing, I'm a big fan of diaphragmatic breathing, but it won't solve all of these issues.
Mhm.
And then also puts the onus on the patient, like you're doing something wrong, right? If
Mhm.
you are too stressed out, you're doing something, you aren't in tune with yourself, fix it, and all this will get better. And I think it's very misleading and inappropriately puts a lot of blame on the patient, which is not great.
And a lot of people who have gastrointestinal problems in this population, they've been to a gastroenterologist. They've done probably some labs. They do celiac testing and maybe a variety of different things. And then, like you said, the ticket to admission is this an upper endoscopy and or lower endoscopy, depending on where your symptoms are, right? So, what is your approach, though? Because I imagine that your approach is quite different to working people up.
Yeah, I mean, it starts with the interview, right? Like
Mhm.
I always have to start with when did things begin, um, and it really is informative. Like, was it a huge GI bug? Right? Was it an infection? Like post-viral, post-COVID, IBS is very, very real.
Mm.
Was it puberty, and then you developed POTS? Right? Was it pregnancy, and then you developed postpartum MCAS? And so I
Mhm.
think that's really helpful in terms of putting this all together because our data tests aren't perfect, and so the clinical history informs of a lot of where I'm going to go, and then I think understanding like your biggest symptom is really helpful because that really tells me like what organ system we're going to start with. I also got to make sure you're pooping well because a lot of people have a lot of issues, and constipation is really challenging. It really is. And people come to me and they're like, "I think I'm dying. I think I have cancer." And we just realize they have a huge stool burden. I don't mean just like when you're not when it can really be quite painful. So
Mhm.
um, yeah, no, it's tricky, but I spend a lot of time with patients, and getting understand the cadence of everything, what makes things worse, what makes things better. We talk about stress and sleep and your job and your relationships and your diet and your medications and all the symptoms, right? You have to do the whole review of systems, right?
Mhm.
To really understand, if MCAS is at play, if hypermobility is at play, and then you do the physical exam, right? And you do the bite and score, but also I don't really love the bite and score. And I've made some posts about that because I've had so many
Yeah.
patients from like, clearly you're hypermobile, but their bite score is like underwhelming. And
Right.
they're like, their skin is like, here, like up to here. And then they have malls and they have thoracic outlet syndrome. And you're like, there's something else going on here. I don't care what the criteria is. Like, I'm just going to treat you as such. But
Right, right. And I do wanna just quickly interject MALS, median arcuate ligament syndrome, for that is one of the compression syndromes. We'll get into that more in just a little bit. So, okay, so you're starting with a
Sorry.
very
Yeah.
no, that's okay. I just like to make sure that people who are not familiar with certain terms that we define them. So it's really important. Who was it? Was it Osler who said, "Listen to the patient; they're telling you the diagnosis." And I feel like now this is such a huge problem, especially like in cardiology, right? That we. I'm a lot older than you are, so like when I was going through my medical school and residency and everything, and as an anesthesiologist, you spend 3 months in cardiology in your intern year, and so you're taught all these things about how to determine what's causing this murmur, right? But now you just like, oh, there's a murmur, I'm going to get an echo. So it's just the art of the physical exam, even I feel like is just not what it used to be.
Absolutely. Absolutely. Yeah. We've come to stop trusting patients because I think we were taught a certain way. And, my textbook, there's, in GI, there's dozens of pages on Crohn's disease and peptic ulcer disease, and irritable bowel syndrome is given 2 pages, but it's infinitely more complex than all of those other pathophysiologies. We have a tough time understanding it.
Hmm.
And so when someone comes to you, similarly with like MCAS or hypermobility, which goodness, there are diagnoses there that I hadn't heard about until I started reading about them. Like cranocervical instability was not on my board exams. Right?
No,
Tether cord was a
right?
new diagnosis to me. And
Right.
so if people come to you with challenges and symptoms that don't fit within your paradigm of what you understand about medicine, then oftentimes it's dismissed like this doesn't exist, or it's stress, or it's anxiety. And people stop becoming curious about why people's symptoms are what they are, and they blame it on anxiety because they're not taking the next step, and it's really challenging for patients. And so people started to just not trust patients. And it's, again, as you mentioned, they'll tell you the story, they'll tell you what's going on. You just have to listen.
Yeah, I think as our labs and imaging have become, more and more sophisticated, so many people think if it's not showing up in the labs and it's not showing up in the imaging, then therefore it does not exist. Which we know there's lots of things that don't show up on, I mean, I've had people say to me so many times, I had every lab test known to mankind, like everything. They tested for everything. And then I look at what they tested for and it's like, there's just obviously there's like an infinite number of tests almost. So it's like, we should always be saying, the test that we ran didn't come up with anything conclusive, but we'll keep looking. And I wish that more people were in a position that they could do that. So I want to talk more about these motility problems because I feel like this is such a common problem that a lot of people face, and you see a lot of people who end up on eventually they might end up on tube feeds and things like this, and it's or TPN even, peripheral nutrition, and that's often we're because they started with kind of a motility problem, and obviously that's a tragic outcome. You can end up with all kinds of, you can get sepsis and clots forming on the line and things like that. So, we really want to try to use the gut, right, as much as we possibly can. And so can you run us through like within the category of motility, maybe I start with slow motility because obviously there's also the opposite, although it sounds like that's a less common. But, how do you kind of distill that out and what kind of things actually can be done for that?
Yeah. So, I think the most common thing that I see is gastroparesis,
Mhm.
right? And it's really tricky. And it's a very elegant pathophysiology, but we just have very elementary tools that we have. We don't get it, right? And so, it always starts with you got to understand the diagnosis first. So, is it gastroparesis? Are they not eating because of SMA syndrome, which is superior mesenteric artery syndrome, where the fat pad is lost between the aorta and the SMA, clamping the duodenum? Do they have median arcuate ligament syndrome, making it really challenging to eat? Do they have IBS and central sensitization, where it hurts to eat? But if we're focusing more on, okay, they have slow motility, they have gastroparesis, like what do we do? So we start with diet first. And that's kind of the ground floor of where we start, and it moves the needle for a lot of people. But for more severe cases, it's not doing a whole heck of a lot. And they've tried everything, but we talk about kind of small frequent meals, trying to introduce fiber that is kind of blended up, de-seeded, de-peeled, not any of that kind
Mm.
of hard soluble fibers. Low, less seeds, less nuts, kind of a blenderized diet, right? Our stomach is a blender, more or less. And if our if the blender's spiral, what word am I looking for? What churns up the
Like the
food
blade?
is dull, The
Like
blade.
the
Oh,
blade?
goodness. I've never used that analogy before, so now I'm I was like, I jumped into that one head first. When the blade is a little bit dull, right, in gastroparesis, you just have to do it a favor, right? So if you want to eat
Mhm.
carrots, you blend it up. If you want to eat apples, blend it up, take the skin off. So I work kind of hand in hand with the dietitian there, not only to identify what you should and should eat, but also calorie counting to make sure that you're getting enough food, and we don't have to go to parental nutrition with TPN.
Mhm.
And let's talk about medications, right? So this is tough. So we use pro-motility agents kind of very apprehensively because they're not great and they have some side effects. So
Mhm.
Reglan is the most notable one, and it really just helps the food move. But studies show that it doesn't work very well. Like it just
Mhm.
doesn't. So it works mechanistically, but it doesn't help with patient symptoms. But if you do Reglan
Mm.
with diet, it does move the needle. If you use Reglan diet and a neuromodulator, it even helps a little bit more. So the neuromodulator is for the pain element of it.
Mm.
Okay, so um, you can use amitriptyline at low doses, nortriptyline at low doses, and what they do is that works at the level of the spinal cord to help tune out some of these inappropriate pain signaling from the gut. But you have to be careful there because it also can slow down motility in the colon. And if you have dysautonomia, it can lead to more orthostasis. So you're balancing all these things, but fortunately, you can get away with like low doses. You can use, Buspar, which helps with gastric accommodation. You can use Cymbalta, kind of less commonly, but Cymbalta also can worsen POTS in some regards because it increases your norepinephrine at the synaptic terminal. So you just have to. There's a balance there.
Mhm.
And then, to go back to pro-motility agents, you can use erythromycin, which is an
Mhm.
antibiotic that increases your motilin, which is, it's usually stimulated by M cells. And so, but that has tachyphylaxis, and that kind of doesn't work in a couple months, and has QTC prolongation. So but I usually blend a pro-motility agent. You can also use precalipride, Motegrity, which works not only proximally but distally as well. And in these dysautonomia patients, where you're generally dealing with kind of global dysmotility, it's not a bad agent, and it's now available on GoodRx for a reasonable
Oh.
price because it is kind of a pain to get.
Mhm.
Yeah, so Motegrity is a good one. Low side effects, hits the serotonin receptors in your gut. And then I'll use kind of a neuromodulator as well to help with the pain too. But everybody's different. Some people don't want to take pain medications, right? And so, how
Mhm.
can you help with the pain nociception centrally? You can also use hypnosis. Like hypnosis has pretty good data for it. You can use cognitive behavioral therapy if you have a lot of kind of thoughts around, like a lot of kind of catastrophic thoughts about what's going to happen. Like if I eat this, I'm going to have
Mhm.
pain all day, and GBT kind of enables you to challenge those thoughts to understand whether they're real or not. Um, and then there's like functional dyspepsia, which is kind of a cousin of gastroparesis, where actually the stomach is moving okay, but you have a lot of pain, and that's kind of a different conversation. But generally speaking, we talk about diet. I use some pro-motility agent if we need to, complement it with some agent to help with central pain processing. And then we always talk about sleep, stress,
Mm.
getting outside, relationships, exercise. And I recognize there are, not everybody can get outside, not everybody can work out and sleep
Mhm.
well. But we tackle all these things because it all blends together. And
Right.
I always tell patients that, like, this is really tricky. And I'm not, when I see in a couple weeks, we're not going to be 100% better, but I'm looking for like
Mhm.
10%, right? And
Mhm.
we're going to be working together for a long time to understand your body and what works for you. And so it's a dance, and we work hard, we work at it together. Oh, another gastroparesis tip: you got to poop. Everything in gastroparesis is worse when you can't poop. So if there's a backup on 95, right, you got to fix where the flames and the car crash is first, and then everything doesn't always rectify itself altogether, but it gets better. So you got to get people pooping. But you're dealing with the same issues, like, why aren't you pooping? Like, people want to poop. Like, it's not just like, oh, go poop. You have to get into that too. So it's it is still it's still a tube. It's an elegant tube. It's still a tube. You got to block the distal. You got to address the distal blockage first before you can confront anything proximally. But that's how
Okay.
I think about gastroparesis.
Okay, that's a super helpful tip. And what I find happening very, very commonly with my patients, and maybe because, my practice is much more focused on pain on the whole, and you're obviously a neurogastroenterologist, so you're focused on more the GI aspect, of course. But what I find is people don't necessarily bring up to me about how often they're pooping. So I have to ask them specifically, and then sometimes they'll be like, "Oh yeah, once a week." I'm like, "Once a week? That's not okay." So and I
But
actually
they have so
had
many other bigger things to talk to you about, right?
exactly,
Like,
exactly.
and
Yeah,
so it's like that's it gets lost in the shuffle. Yeah.
yeah.
I would want to say that you got to make sure a lot of patients have MCAS too. So MCAS can cause pain as well. So before kind of before saying, okay, your gastroparesis, there's a pain element to that we have to treat, or you have to make sure there's no MCAS, make sure there's no moles, because moles can cause postprandial abdominal pain. And we can talk in, I don't know if you want to dive into the pathophysiology there or talk about the rectum and how challenging it is to poop. We can jump around
Yeah,
anatomically. Um, I'll let you
yeah,
drive the ship though.
yeah, it's really hard not to kind of jump around a little bit, so, hopefully people are gonna bear with us with that. I did have a question. Okay, so bowel movements. What is the goal? What is the goal for bowel movements? So I feel like that's a good, yeah, important
Think
thing.
whatever makes you comfortable, right?
Mm,
Fecal stasis doesn't cause any problems if you're not symptomatic.
mm,
So there are people that poop once a week and they're like okay with it.
mm,
And if they're okay with it and they're not bloated and not uncomfortable, then that's totally fine. There's this
mm,
kind of like poop 3 times a day or once every 3 days, but I find there's great variability there. And
mm.
look, once you get to like the 7, 8 days, like people generally are pretty symptomatic. Or if you probe, they're like, yeah, I get full a little early and I failed 4 colonoscopies in a row and I'm bloated. And you're like, okay, well, maybe we have to deal with this.
Mhm.
But generally speaking, if you're bloated and uncomfortable and have discomfort, like we should address it.
So the goal of, like, going every day is not necessarily something that we should have for everybody.
No, it's like saying like, I like my haircut, but if I had Dr. Bluestein's hair in my head, like I don't want that. I think your hair is fantastic. I don't want your hair in my head. Or like you're pooping the amount that you need to poop, and I don't
Okay,
want. You can't apply that template to anybody else,
okay,
um, because they're not going to feel great.
okay. Well, that's
And
really
then,
good
and
to
also like women and men have huge disparities in how well their colon moves. So men's
mm,
colons move a lot faster than women's.
mm,
Estrogen tends to be the stop break on the colon, and
mm.
that's why postmenopausal a lot of women get a little. I mean, they in that perimenopause, postmenopausal phase, you can get a little more constipated because the estrogen isn't there. There's also more twists and turns, right? Um, and the pelvic organs are just they have an impact on the relative movements of the colon too. So yeah, everybody's different.
Before we move on to, compression syndromes and SIBO and visceroptosis and all these other things that we wanna try to cover, while we're still on the motility problems, what are your thoughts about, Mestinon or prostaglandin for POTS and how that might potentially impact the motility?
Yeah, so I use Mestinon for POTS for sure.
Mhm,
It is not the first thing I go to, but if we
mhm,
need kind of a relative reduction in your heart rate without compromising your blood pressure, and there's concomitant GI issues like slow motility, then I will use it. I
mhm,
don't think it like is a game changer. I think it's an adjunct therapy. Like I don't think
mhm,
I've ever put anybody on it and then everything turned around because if you think mechanistically, and I'm probably oversimplifying it, is that you have this uh, kind of autonomic imbalance in postural orthostatic tachycardia syndrome, where your sympathetic is a little bit more is higher than your parasympathetic, and the methadone just kind of does this. But does it really
mhm,
dampen your sympathetic drive? Like I don't think so. I
mhm.
think it just increases your parasympathetic arm, so it can take the edge off. But I don't think it's everything. Like mechanistically, theoretically, it should work better, but I don't find it to be a complete game changer. But it is a weapon, or not a weapon, a tool that I have, and I think I'll certainly use.
Last question about the, motility issue or comment or whatever was that I had a patient the other day who had such bad colonic inertia. Can't remember how old she was when she had this surgery, but she had a massive amount of her colon actually, removed. And she said it dramatically helped her from the standpoint of, having bowel movements. But wow, that seems like really, that's pretty aggressive, right? And then you have all kinds of other problems, I would think, after that.
Yeah, that's a tough one. I've only sent one patient to surgery, and she had some mitochondrial deficit that was just horrendous, and
Mm,
just we couldn't overcome it. But you can throw the kitchen sink at these patients. You one have to make sure there's no outflow obstruction, that there's no pelvic floor dyssynergia.
mhm.
So make we always, you want to kind of ask the right questions to tease that out, and then diet, some kind of low fermentable fiber, laxatives. So you can throw some pretty hardcore medications at these patients' physiology and hopefully move the needle. And when we're getting really desperate, I'll combine, a secretagogue like linaclotide, which effectively pulls water into the intestines and makes the stool softer, combined with a stimulant agent like motegrity, which helps the colon squeeze. So you're making the stool soft, simultaneously helping the colon squeeze, increasing water, movement, making sure that you have the proper pooping position. So it's kind of an all hands on deck approach.
Yeah, and I certainly hope that more gastroenterologists become interested in helping this populations of patients, because I'm sure you can't see everybody, and so there's way more people that need help than there are clinicians that can help them. It's a huge problem.
Yeah, it's such a fascinating field. It really is. And you get to really connect with people as opposed to just connecting with their colons. Like when I was just, I'm doing my general GI days and I'm fixing dysphagia and taking out polyps. You're like, I just have a relationship with the mucosal layer of your colon. Like that's all I know about you. But you get to, but you get to, the challenging thing, but also the beautiful thing is that there's so many different levers to pull. Like you can talk about the mental health and the diet and the movement, and there's so many different inputs to your GI health and how you perceive it. So you can either think of this as very overwhelming or think of this as an opportunity to positively affect GI health through all of these avenues.
Yeah. Yeah. No, I think that's great because, like, I had my screening colonoscopy, just, routine not that long ago. And I never saw the gastroenterologist beforehand. It was all scheduled. I got all my instructions and everything, showed up at the hospital. Same thing for my husband. We had different gastroenterologists, but literally showed up at the hospital and met this person for the first time right before the procedure. I'd already done the prep and, everything. And so, yeah, it's a completely different relationship that you're talking about.
It's pretty strange, isn't it? Being such a
Yeah.
vulnerable person. I'm like, hey, I'm Dave. I'm going to take a look in your colon and I'll
Yeah.
probably never see you again.
Yeah. Yeah.
It's very strange.
It is very strange.
It's
And when
very
I was
strange.
when I was having more GI problems, um, back when I was living in Wisconsin, and I remember I was going to be having a screening colonoscopy, and I tried to start talking about some of the issues that I had. Like, here, I'm going to be having this colonoscopy. Is there anything additional that we should be doing for diagnostic purposes? And this is before I knew about MCAS, because otherwise I would have said, hey, could you do biopsies and look for mast cells and see if there are more
Yeah.
abnormally shaped or whatever. But anyway, so yeah, I think there's different ways that people practice and different interests that people have, of course. So we're going to take a quick break, and when we come back, we are going to try to tackle the other, I don't know how many things on the list, SIBO, gluten intolerance, visceraptosis. We'll see. We'll see what we get to. So we'll be right back. Okay, we are back with Dr. Spiritos. This is such a great conversation, and I know that there's so many things that we could talk about, and I feel like we just have to kind of like pick the most important ones. And I do want people to be able to walk away with some pearls. And already you've given us tons. You've already given us a bunch of different ideas of things that can be done for motility problems. We kind of covered that a little bit more in detail in the first part. I was wondering if maybe we could talk about SIBO. I hate to say briefly, but I guess when
Okay.
do you suspect it? What kind of workup do you do, and how do you treat it? In 5 minutes or less. Just kidding.
Yeah, so small intestinal bacterial overgrowth is where there's a superfluous amount of bacteria in the intestines. Mark Pimentel is a thought leader here. I kind of follow his lead. If you want to learn more, I would look up his talks. He's dedicated his whole life to this tricky phenomenon. Um, he describes it more of as an infection, right? It's like an overgrowth in the small bowel, as opposed to previously we thought that there was kind of the bacteria should be in the colon
Mhm.
where it's more alkaline and they kind of propagate up to the small bowel, but we're realizing that it's just an overgrowth. It's almost like an infection. Um, we're starting to understand the exact bacterial strains that cause SIBO as well, which is kind of cool. Um, Biggest risk factors are really, where the small bowel can't clear adequately.
Mm.
So the small bowel has kind of regulatory mechanisms like the migrating motor complex to kind of clear. It's like the Zamboni to clear the small bowel of bacteria because it shouldn't be there,
Mhm.
or they should be there in relatively small amounts. Um, and so risk factors for kind of that not working so well is dysautonomia, because that vagal input in your small bowel just isn't as effective as it should be. So it's either poorly coordinated or kind of dampen down kind of peristalsis, so the small bowel can't clear the bacteria. Narcotics is a big one, just because the small bowel narcotics are a stop break for the entire GI system. Prior GI surgeries, just because you can get kind of adhesions and stasis of certain areas, because once you have you have your abdomen open, whether it's a cholecystectomy, kind of hysterectomy, etc., you'll get adhesions there from the prior inflammation, and that just kind of distorts the way the bowel can move sometimes. So those are like the general risk factors. Some people think prior cholecystectomy is a risk factor, or PPI use, but the data isn't quite there. But I understand kind of theoretically how that can happen. So that will always perk my ears up a little bit. The cardinal symptom is bloating. It's tough to get beyond, really look for it if you're not bloated, but I sometimes do if the shoe fits. And then you can either have constipation if you have M. smithii, which is an archaea, which is not really a bacteria, but an archaea that increases your methane production, which can slow down colonic motility. So that SIBO, or it's called IMO, intestinal methanogen overgrowth, can cause constipation. Traditional SIBO is, I believe it's an E. coli and Klebsiella species that cause a lot of bloating and diarrhea or loose stools. So that's where I start. So risk factors for it, the symptoms, bloating and bowel abnormalities, and then I test for it. So we use a hydrogen breath test or a lactulose breath test. I use lactulose. It's a little bit more sensitive, so you get more false positives, but I'd love to have more false positives and false negatives. And then we treat it. I go with the data, and I use rifaximin a lot for, hydrogen producing or SIBO. That's a traditional type. Rifaximin works well. It's a eubiotic. It's not an antibiotic, so it doesn't work everywhere in the body. It just shifts the bacteria to a healthier one. So, getting insurance approval is kind of a beast sometimes. So that's kind of unfortunate, but it works well, and it's for 14 days. Some people do want herbs though. So I do have herbal remedies. There's just not a lot of studies for it. There's a couple, right? But they're in a handful of patients. So it hasn't been reproduced on a larger scale in a randomized control fashion. So I'm a little bit hesitant to do so. I always choose rifaximin, but I always try to meet a patient where they are. So if they want to do herbs, let's do some herbs. And I have my own not my own protocols, but I've looked up and I've researched in terms of what berberine does and what garlic does and what all these other agents do. I'm not integrative trained, but I certainly embrace it when people want me to go down that route. So, but I will say that the data hasn't shown that it's as effective as rifaximin. And then there's different treatments there's also a hydrogen sulfide SIBO variant that Dr. Pimentel has recently identified. So that's kind of a new agent. And then for intestinal methanogen overgrowth, it's a combination of neomycin and rifaximin. So a different antibiotic choice there. So yeah, I treat it when I see it, but there's also false positives. So when we treat it, I'll say this may not be it. This may not be it. And we may have to continue to fight. Occasionally we'll treat SIBO and everything gets better. But it's usually in someone who has had a recent bariatric surgery, and then they develop tons of bloating, and then we treat it and it gets better. And it's really ever the whole thing. Sometimes it is. There is a high recurrence rate, about 40%, just because you can't really fix the underlying pathophysiology unless the bowel is slow due to narcotics, and then you just wean off narcotics, which obviously easier said than done. But if you have underlying dysmotility or stasis from prior bariatric surgeries, it certainly can come back. There are a couple approaches there. You just kind of continue to treat it when it comes back, and people don't love that for obvious reasons. But if you do have recurrence, or just I got treated once, I never want to go through this again, then we can talk about pro-motility agents to kind of keep the bowel going. And so Motegrity is my first choice there, because it does work throughout the entire GI tract, both proximally and distally, to help the colon squeeze and allow the small bowel to kind of get rid of those excess bugs. Someone asked me about garlic. Fine. If you have IBS, garlic has it's a FODMAP bomb. So you got to have to take that into consideration. It's also just not well studied, right? And so that's where I always have a little bit of a hang up with these, because there's not long-term data for use of this and how effective it is, how to dose it, how long to use it for. And there's information out there. It's just not incredibly well validated to what I've seen. And if I'm wrong, please send me data. So I always, but Motegrity is my go-to, and you can use erythromycin as well. But there's also those issues that I spoke about before with the tachyphylaxis, where in 6 months it stopped the work as well. And there's also QTC prolongation issues. So you just got to take all this into consideration.
And what about patients that are taking Zofran or ondansetron for their nausea, and that because that also slows transit, right? So could that contribute? Or
I think so. I don't think there's that many, in these studies. That's a great question, because Zofran can definitely cause constipation and hit on, the way that motegrity works. Zofran works in the opposite way. It still works on those serotonergic receptors. So I imagine so. I don't know how many people are on Zofran chronically. Like obviously we want to stop that as soon as possible. But I don't know if that's well studied, but it certainly would make sense. When you're doing the SIBO test, it's very protocolized. You have to follow a specific diet, remove certain medications before you take it to not alter kind of your native GI motility. So I imagine you'd probably take someone off Zofran before testing for it. But at the same time, if you're on it chronically, and that's why you have SIBO, maybe you just test while on it. But it's a really good question. Yeah.
yeah, and it's really interesting because I have a lot of patients who do take it quite regularly because they have nausea from their pots. And so we try to, get to the root cause and try to see if we can get their pots better some other way because that can also cause headaches and that also causes QT problems as well. So anyway, I was just curious about that little side note. And then I had never heard the term before, eubiotics. That's fascinating. And I know there's home tests for SIBO, and I was wondering if those home tests for SIBO are as accurate, the direct to
I
consumer
don't
type
know.
tests. Yeah.
I
Okay.
don't think so. I don't think
Okay.
so. I
Yeah.
haven't sniffed it out, but I use the Trio Smart.
Okay.
Dr. Pimentel's. I know he's such a thought leader, and he has this Trio Smart brand of SIBO testing that I use because it also picks up on hydrogen sulfide variants of SIBO, which isn't picked up on the other tests. Sometimes in the other tests, if you have like flat lines of both hydrogen methane, it could be like this could be hydrogen sulfide, but it's not. It's guessing. So I use the Trio Smart because it has all three. It tests for all three. Um,
Okay.
I want to talk about chronic nausea really quickly.
Okay.
So it can happen for sure. And I have a lot of patients with dysautonomia and not with dysautonomia who have chronic nausea, and they get sent
Mhm.
to a GI doctor, even though chronic nausea, so postprandial nausea is different. After eating nausea is ulcers, dysmotility, gastroparesis, but chronic nausea that is around the clock and often worse in the morning, I often find that's due to an overly active sympathetic drive, right? And the
Mm.
nausea the signal for nausea is in the hindbrain. It's not actually in the GI tract. And so Zofran works primarily in the brain, doesn't work peripherally. Reglan works in both areas. So I use a medication called mirtazapine a lot for that. Obviously,
Mm.
you want to kind of work on sleep and work on cerebral perfusion if someone has dysautonomia. But Reglan mirtazapine works really well to dampen down those those nausea receptors in the brain.
Interesting.
And I often find these patients have a difficult time sleeping as well, and it helps with sleep, helps with appetite a little bit. It's really, really safe. It was used as an antidepressant many, many years ago, but you're using it subtherapeutic doses at 7.5 or 15 at night.
Mm.
So I think it's a really nice adjunct to at least get people off Zofran just because of the QTC. And, you're handcuffed to taking the medication a couple times a day. Does it work all the time? It doesn't, but it's a nice option to try to make that change to something a little safer.
Okay. No, that's excellent to know because, yeah, the chronic nausea, like you said, with or without dysautonomia, is a common thing that seems like we see. So thank you for sharing that. So would it be okay to move on to compression syndromes?
Yeah,
Okay.
for sure.
So what should we, because, I want to be respectful of your time. So I'm like watching the clock and making sure, okay, what do we want to make sure we cover in the time that we have left? So what should we know about compression syndromes in terms of um, how they, and I understand that this is a very big question, obviously, because there's multiple different ones and what symptoms they present with are a little bit different. But, if you could give us kind of a 10,000-foot overview in terms of who should be evaluated for these and what kind of workup and treatment might be considered.
Yeah, in terms of compression syndromes that cause GI symptoms, like not talking about May-Thurner or Nutcracker,
Uh-huh.
which is a little bit different, that can affect people with dysautonomia and affect their volume status. But for compression syndromes that affect the GI tract, the first one we talk about is median arcuate ligament syndrome. And so the median arcuate ligament is this ligament that that kind of originates from the diaphragmatic crura, so where the kind of the crosshatch of where our diaphragm lives. And it's supposed to sit superior or above our celiac artery and our celiac ganglion. And so the traditional teaching was that in median arcuate ligament syndrome, one, it just never happens. It's just incredibly rare. It's a zebra, which, to be fair, it is in patients that probably don't have dysautonomia and don't have hypermobility. But the pathophysiology is that that ligament starts to compress the celiac artery. And so when you eat, you get relative ischemia of your stomach. So it just hurts. It's like a heart attack of your gut, because the celiac artery perfuses a good part of the stomach. And so you tend to get pain after eating, pain with exercising. And there's certain ways that people can kind of manipulate their body to relieve that pressure. So like leaning forward, kind of downward dog, exhalation can help with the pain. That's the teaching, but it behaves certainly differently. But there's also another school of thought, which I very much believe in, is that it's not only that ligament compressing the artery, but compressing the celiac ganglion, which is the nerve, the family of nerves that innervate the stomach. So it can be an ischemic presentation or ischemic etiology where it's compressing the artery, but I think that the majority of patients that have pain, it's a neuropathy where it's pressing the nerve bundle. So it's kind of like a complex regional pain syndrome of the gut. And so the traditional testing we use for mols is an ultrasound with inhalation and expiration to see if kind of during inhalation that ligament squeezes the artery. But if it's negative, it doesn't really touch on whether it's how it interacts with the celiac ganglion. And from what I've seen is that even like CT scans, I can somehow see this hooking sign of mols, which is pathognomonic for that, or an MRI, it's tough to see the relation between the celiac ganglion and the ligament. So if we have a high degree of suspicion for this, you are the right person. The symptoms fit. We cannot account for your symptoms with any other pathophysiology. You are not responding to treatments that treat anything else. Then we will send you for a celiac ganglion plexus block. But it can be tough because it's hard to get it approved, because I believe the kind of approved indications is for pancreas cancer, like pain due to that, right? Is it completely benign? I think it's a pretty safe procedure. So it's all kind of a risk benefit conversation. But if you're really having a tough time with this and we don't really have any other options and the testing is negative, I'll empirically send you for this after a thoughtful discussion with the patient to see if this makes you feel better. And it is a proof of concept. If it does get better, then we could talk about identifying a surgeon that can take care of it by kind of peeling that ligament off of the plexus.
Okay, yeah, I used to do celiac plexus blocks when I was in my residency, doing my pain rotations, and like you said, it's not a completely benign procedure, not super high risk now with our imaging that we're able to do and things like that, but definitely you don't want to be just doing that willy-nilly. Like you said, you want to be very very selective for a wide variety of reasons. Also, it is expensive. It's an invasive kind of thing. So okay, that's super helpful. And then what about SMAS?
Yeah, so SMAS is superior mesenteric artery syndrome, which is where the second part of the duodenum, so how we're constructed is our esophagus, our stomach, the duodenal bulb, first part of the duodenum, second part of the duodenum, third, fourth, jejunum ileum. So the second part of the duodenum, as it crosses midline, lives between the bifurcation of the aorta and superior mesenteric artery. So the traditional thinking is that people lose that fat pad. So there's a fat pad that kind of lines this kind of the joining of these two arteries. And if you lose a lot of weight quickly, or you have some kind of spinal manipulation, cervical spinal manipulation, that can close. And so it just shuts that D2. So you get a lot of obstructive symptoms, like what you see with gastric outlet obstruction. So nausea, inability to eat a lot, some pain, but I think the nausea element is pretty strong. And so it can behave somewhat like gastroparesis. But I think that this can happen to people with hypermobility outside of the circumstances with which I described, the rapid weight loss, the cervical manipulation, just because they're hypermobile, the kind of the takeoff from the SMA from the aorta is a little bit different. Everything's there's ptosis of everything more, not only of the organs, but the vasculature, and that can kind of compress the duodenum as well. That's a little bit more easy to diagnose. So obviously the clinical history, negative endoscopy, normal gastric emptying study, and then you can get this kind of small bowel follow through where people drink contrast and it passes through your stomach into your small bowel. And if there's hang up between D2 and T3, that could be suspicion for it. And the treatment that we have is weight gain. It's kind of build up that fat pad. So that angle becomes a little bit more obtuse. And so sometimes we have to do TPN. You can certainly do, if you can get a GJ tube past the obstruction, which is easier said than done. Sometimes an advanced endoscopist can do that. So again, it's a tricky situation. You just kind of have to weigh the options and what the patient wants to do and what resources are available locally.
That's great. That's great to have those two syndromes pretty clearly defined and what our options are. So let's also talk about something. Let's back up to something that's a little bit more, I don't want to say mundane, but like super common, I think. Glucose intolerance. Not celiac, but it seems like this is something that a lot of people are dealing with when they have mast cell activation and this complex of conditions.
Yeah, no, it's a good point. So gluten intolerance is tricky. So obviously you want to make sure that people don't have celiac disease, which is a distinct autoimmune condition.
Mhm.
And then you know, you kind of take the patient's lead to see how they feel after eating gluten. Some people, there's kind of non-celiac gluten sensitivity where people not only get GI symptoms, but they get brain fog, fatigue, muscle aches. And the question is that mast cell or is that non-celiac gluten sensitivity? We're quickly learning that some of these conditions that are previously poorly defined, like interstitial cystitis, have a mast cell component to it. So is non-celiac gluten sensitivity, is that just gluten that's irritating your mast cells? Like, I don't
Mhm.
think we know just yet.
Mhm.
Um, and then in cases of irritable bowel syndrome, some people think that they are gluten intolerant, but it's the FODMAPs that really cause a lot of bloating, distension, and
Mm.
pain. So a FODMAP is a fermentable oligodimonosaccharide in polyol, or it's a stupidly long name for a poorly absorbed uh, carbohydrate that kind of makes its way. It evades digestion in the small intestine, comes into the colon, and the kind of native bacteria there turn that into a lot of gas, and that distension can cause pain in patients with irritable bowel syndrome. But those symptoms are more localized to the GI tract, um, and it's not gluten per se, but it's the fructans in wheat. So wheat simultaneously has fructans and it has gluten.
Mm.
Um, so it's really tough to tease it out. I don't empirically put people on a gluten-free diet, although I'm hearing more and more that like maybe I should.
Mm.
Um, again, you don't want to overly restrict people. And I
Mhm.
hate to restrict people when there's not a lot of data to support that it helps a lot of folks. Like it certainly helps some people, but not everybody. And so that's where I think keeping a very detailed um, symptom diary is really helpful, along with like a food diary to understand what your triggers are. Because, when you eat something, it can affect you 30 minutes later, like in like histamine intolerance. But in, IBS or non-celiac gluten sensitivity, like it can be 6 to 8 hours later. So
Mhm.
I am a big proponent of keeping a strict food and symptom diary to understand what's what. But it's a hot button topic. I think I gave a very like nebulous answer there. Um, but if it makes you feel better, great. Stop it. We got to make sure you don't have celiac disease because that portends like you really have to be incredibly strict there because there's a risk for vitamin deficiencies, nutrient deficiencies, small bowel lymphoma. But for the most part, if it makes you feel better, then by all means cut it out. But I have an incomplete understanding of gluten, I think, and how it works in the body.
Yeah, I feel like it's so complicated, and I feel like, so much of what you were talking about earlier feeds into this. Like you said, people, if you eat certain things and then you're trying to figure out what it was that caused those symptoms, and then you're, okay, well, I'm gonna eliminate this and I'm gonna eliminate that, and next thing you know, I mean, I've had people that, come to me and they're eating literally 3 things. It's like, and that
Yeah, it's
obviously,
and
yeah.
it's called a avoidant restrictive food intake disorder. It's really tricky because there's so much anxiety around eating. Like eating should bring
Mhm.
us together. It should be a happy moment, and it should be shared and enjoyed. And so, I think one of the challenges, but the kind of great pleasures that I get in clinic is identifying underlying pathophysiology, so we can definitively say, okay, this is what you can eat, this is what you can eat, and then working with a GI savvy dietitian to reintroduce foods in a safe way. And I think that partnership is really important as well, is
Mhm.
identifying a dietitian on your team that can really help these people, not only with identifying the foods to eat, not to eat, but also talking about the anxieties around eating. And that's
Mhm.
it's tough. It's really challenging.
So you do have a dietitian on your team?
I do.
Okay,
I do.
yeah, that I think that is so important because that, I get so many questions about that. In fact, that's part of the, like, last part of the questions, but we're gonna be running out of time. Low histamine diet, do you do it forever? And, of course, the low histamine diet, what is a problem for some people, it's not a problem for other people, just because a food is supposed to be, higher in histamine. I find that there's a lot of individual variation there. Somebody else asked, how do you increase tolerance to foods? Other people asked about over-restriction, about meal timing, a lot of questions related to food, but, it would be really hard to get into all of those. And I want to make sure we kind of focus on the things that are more specific to what you're doing. So can we talk in the last few minutes that we have, can we talk first about PPIs and what your thoughts are about proton pump inhibitors, the good, the bad, the ugly? Because people tend to get started on them, right? And then they never get stopped.
Yeah. So there are clear examples where they are so incredibly helpful. And
Mhm.
everything in medicine is a risk benefit
Right.
conversation. And so if you just have some random GI cramp and you're put on a PPI, you got to get off it, right? But if you have horrible erosive esophagitis from gastroesophageal reflux disease, if you have peptic ulcer disease that is recalcitrant for whatever reason, or have a marginal ulcer from bariatric surgery, or Barrett's esophagus, or eosinophilic esophagitis, there is clear data that it has benefit. Okay.
Mhm.
Obviously, we want to get you off it if we can, but it's a safe medication. That's just what the data tells us. So the best studies out there show that it can potentially cause two different conditions. One is intestinal infections, and the thought being that, you're kind of the low pH of your stomach should kill off you ate Uncle Bob's undercooked chicken and there's some E. coli there, your stomach acid should be able to kill it off. But if you're on a PPI, that could potentially propagate your colon, leading to a colitis. So that's one, but I've personally never seen it happen. So, but it's definitely a risk out there. Um, and and then potentially bone density loss.
Mhm.
And so the studies haven't been consistent in showing that. But if I find that if I have someone who's a postmenopausal woman, who is over the age of, who's thin, definitely is a smoker, and I'm like, okay, we should move towards something else here to not increase that osteoporotic risk. But, everything that suggests that it causes, mineral loss, Alzheimer's, cancers, they're all correlation studies. So they study these people that have X conditions and say, let's look back and see if they were on a PPI. And it turns out when you study people who have a lot of diagnoses, like advanced renal dysfunction and dementia and cancer, that at some point in time they were put on a PPI, but it
Mhm.
doesn't suggest causation. And so I think the bottom line is this philosophy is the same for any therapy, intervention in medicine. It's weighing the risks and the benefits.
Mhm.
But it is a safe medication.
Okay. What about GLP-1s, glucagon-like peptide agonist receptor medications? So we know this obviously could also be its own episode, but a lot of people now are, they came across this study where it improved mast cell in one patient in a case study. But I've had patients for whom, they've experienced some weight gain and they're really concerned about it. And they didn't really have much in the way of symptoms of gastroparesis and they really, really wanted to try it. So I've started them on super, super low dose. And I've had some people really feel that they've gotten some improvement from it. Also some anti-inflammatory effects, et cetera. Is that something that you prescribe at all, or what? Do you have any?
It's a fantastic medication. It really is. If used appropriately, right?
Mhm.
And so I have people who end up in my clinic with horrible constipation, horrible nausea, because somebody put them on a medication in the GLP-1 GIP family and said, okay, take this dose for 4 weeks, and then you're going to increase it. And then
Mm.
4 weeks after that, you're going to increase it again.
Mhm.
It's like the Wolf of Wall Street dialogue with Matthew McConaughey. He's like, in 10 minutes, give me another vodka martini. And he's just like, he kept, and they just like, it's this kind of plan on autopilot.
Right.
And that's just not how it should be used. And its analogy is like, if I'm on amlodipine 10, like, let's just increase it every week until I'm going to feel better, right? Like, that's just not how medications work. But they have so many incredible benefits. And, obviously weight loss, right? There's people who have immense kind of food noise where all they do is just their brain just tells them to eat food, right? And it's
Mhm.
this kind of real chemical dependency in food, and it kind of can turn down that, and in turn can it helps with liver health, and it decreases kind of metabolic associated steatotic liver disease, or
Mm.
previously known as fatty liver disease, and it's now FDA approved for sleep apnea, so it has all these amazing benefits for people with underlying metabolic dysfunction. Um, but then you take it to the MCAS patient population who could have underlying gastroparesis, it gets a little tricky.
Hmm.
I will say that I have used it in people with gastroparesis without any problems.
Hmm.
So does it create delayed gastric emptying? Yes. If your symptoms are fairly well controlled though, and you can eat, there's some people who have horrible gastroparesis and things just sit there forever and ever and they vomit, like that's just not going to be an option. But
Right.
for patients with kind of more mild phenotype or moderate phenotype of gastroparesis, you can say we're going to try it and we're going to give
Hmm.
it a shot at a very low dose, right? And then we touch base every week or two and see how you do. And obviously we can always peel it off if it's not working for you. So I think I don't think having gastroparesis is a non-starter for GIPs and GLPs. And I think for the right person, it's a really nice option.
Okay. Getting to the end of my list of questions, of course, we had to, you know, go through some of these pretty quickly. I want to come back and talk about visceroptosis at some point, maybe for part two. Um, what about questions to finding a good specialist when you have a lot of GI symptoms, and questions to ask the gastroenterologist to see if they're a good fit? And Kate specifically asked, one of my followers specifically asked, why do doctors treat GI issues as if they're not connected to EDS, which we know that is a problem?
I think doctors don't know a lot about EDS. They just don't. I didn't know about it until a couple years ago. Throughout all of my training, we didn't pay attention to it. The EDS body behaves so differently than someone without a underlying connective tissue disorder. There's new diagnoses, this new pathophysiology, and traditional GI doctors work with hardware issues. They work with plumbing issues. Is
Right.
something wrong with the tube?
Mhm.
Right? Is there an ulcer here? Is there inflammation here? Can I biopsy and find H. pylori or some pathology? And if I can, then it's probably IBS, right? And
Mhm.
that's where it gets a little tricky. Does IBS exist? I'm not sure. I think IBS is this kind of catch-all diagnosis for people who have symptoms, but goodness, nothing is showing up on testing. So I think to Kate's question is that a lot of people just don't understand EDS. And I'm trying to learn it. I have an incomplete understanding of it. And I get taught by patients every day about how
Mhm.
their body works because I think as a medical community, we fall short in terms of our understanding of this condition. Um, yes, we don't understand that. We don't understand IBS very well. The majority of GI doctors don't understand IBS. I read about IBS and think about IBS every day, every single day, and I'm still learning on a daily basis because
Wow.
we're still kind of understanding what connects to what. And everybody's IBS is different. Is it located in the gut? Is it due to too much gut stress? Is it due to dysbiosis? Is it due to increased serotonin pathways? Is it due to altered bile salt metabolism? So it just can get so tricky and it's so heterogeneous. So finding your team is the other part of the question. And this is really tricky. I think finding a neuro GI is really, really helpful. But there's certainly a lot of other people who want to be creative and think outside the box. And I think you just have to find someone who's on your team, right? And so even if they're like, look, I'm not quite sure how this fits together right now. Like I'm going to read or I'm going to ask questions. We're going to find you someone who can help you, or I'm going to read and I'll get back to you.
Mhm.
But when someone shuts the door and says, "Hey, this is IBS," meditate or give you some kind of banal, unoriginal thoughts about IBS that probably won't move the needle very much, that's when it's time to move on. But I think you just need a partner in this because
Mhm.
even in someone who I think I'm relatively savvy in this, and I read a lot and I think about this all the time. I'm still rather unclear about how this is going to go with my patients. And I'm very
Mhm.
upfront about that. I'm candid. Like a lot of this is trial and error. This is not an opacity on a chest x-ray or a broken ankle where we're going to fix it and you're going to get better. We're going to have to work together. We're going to start things. We're going to stop things. You're going to have to let me know how things are going. And that's how we're going to proceed. So you just need someone who's will listen to you and fight on your behalf.
Mhm.
And I think you can know pretty quickly in the interview if that person's the right person for you.
Mhm.
But I do think like patient forums are great. I think they'll tell you who's pot savvy, who's EDS savvy. Obviously, like the bigger websites like Dysautonomia International. There's a MASA website, the EDS Society. There's resources there as well.
Okay, that's great. And as you know, we end every episode with a hypermobility hack. Do you have one for us?
You gotta learn how to poop. Everybody's got to learn how to poop. That stupid, stupid toilet that they made, that porcelain throne, it's a piece of junk and it's not conducive to good pooping. So yeah, a lot of people, with um, hypermobility, dysautonomia have issues pooping, whether that's slow transit or they can't eat fiber or they have visceroptosis and everything just kind of sags and they have pelvic floor dysfunction because in EDS you kind of compensate for the collagen laxity. So all those muscles get really tight and tense. So we all have to be able to poop. And it's kind of low hanging fruit. We can all do it. And I'm going to kind of walk through a couple of steps here, if that's okay with you, because this is
Yes, please.
a spiel that I like to do. And if this is too weird or gross, please tell me to shut up. But so squatty potty is fantastic. So you want to get your knees above your waist or your hips when you're pooping to really open up that rectal angle. There's something called the puborectalis muscle. It's kind of a sling, and it kind of like cuts off the rectum, and then it opens when our knees are above our waist. So that's where I would start. Um, and then a lot of people have very tense pelvic muscles who are constipated. And so diaphragmatic breathing on the commode is also really nice, as opposed to doom scrolling on Instagram or checking your FanDuel. You really want to work on relaxing your pelvic floor. So diaphragmatic breathing is a really nice trick there. I like Megan Reel's video. She's from Michigan. She's brilliant. She's a GI psychologist, has a great demonstration of diaphragmatic breathing. One hand on your chest, one hand in your belly. Breathe and just push out your belly and make sure this hand in your chest is really stable. Okay. Practice a couple times a day for 5 minutes each. And you just want to think about your pelvic floor relaxing. And then step 3 is pushing. So you don't want to strain, but a gentle push. Breathe in through your nose and then kind of breathe out through your mouth like you're fogging up a mirror, like, and try to feel that rectum evacuate. And it gets, there's more nuance to it. And I'm by no means a pelvic floor physical therapist, but I love my pelvic floor physical therapists.
Yes.
They are just an invaluable member of the team. But that's where I start with everybody, because if you don't assume proper pooping position, you're fighting an uphill battle, and you can throw all the laxatives and fiber and belly massages in the world that you want, but that's pretty critical.
Yeah, no, that's great. And we did an episode on pelvic floor PT that I will also link in the show notes so people can check that out. No, that's super important. And if can I take 3 to 5 more minutes of your time?
Yeah, absolutely.
Okay, because I feel like I do want to just, if you can give me 3 to 5 minutes on visceroptosis, like, again, what is it? Why do people with EDS need to know about it? And how do you work it up and what do you do about it? And I know that that's like an unfair question to say, hey, can you cover this in 3 to 5 minutes? But I feel like we should at least give people something, since we did mention it a few times. I mentioned it multiple times, and I feel like it's kind of unfair to not at least give people something to walk away with.
Yeah, no, it's a diagnosis that we make, but the interventions can be they're tough. They're tough. So it's ptosis is just sagging, right? So ptosis of your eye and myasthenia gravis, your eye sags, right? And so it's just ptosis of all of your organs, because that the architecture, the scaffolding of your organs isn't as robust as it should be, just because of those innate defects in collagen and hypermobility. So everything sags. So a lot of people have like a kind of a more protuberant lower belly because all the organs just kind of sag more kind of lower into their abdominal cavity. So, one thing that makes people feel better is just kind of abdominal binder, just kind of hold everything up. And, ideally you'd want to hoist everything up, but we can't do that. It's just, we don't have those abilities, and going in and doing surgery is not generally a good idea. So abdominal binders, decreasing the amount of kind of gas load in your intestines. So I generally recommend like a lower FODMAP diet. I'll do a modified lower FODMAP diet. So I'll kind of pick out things that are higher in FODMAPs, which again, these kind of non-absorbable carbohydrates that can cause a lot of gas. I'll treat SIBO, because if you have kind of sagging organs, just the motility won't be as robust. So if there's concomitant SIBO, I'll treat that as well. Introducing fiber in a safe way. So a lot of these folks have kind of slow motility. So the fiber that you give like gels up, gunks up, creates a lot of fermentation, which stinks and is uncomfortable. So partially hydrolyzed guar gum is a nice, non-gellable, low fermentation fiber supplement that I often use in these patients. Proper pooping position is really, really helpful too. Working with a pelvic floor physical therapist, really nice. Pro-motility agents, if you need them to kind of help the colon squeeze. Obviously, we can't reverse the ptosis, but we can alleviate some of the symptoms, the bloating symptoms, the kind of sagging feelings with a kind of abdominal binder. Any constipation, we can treat that with laxative diet, make proper pooping position, working with a pelvic floor physical therapist. And, last resort, you do surgery. And some people may need like an endostomy or an encolostomy, which is not our goal. And
Mhm.
I've actually never seen that happen in real life. There's often kind of workarounds there, but it's just something that we kind of have to deal with. I can't reverse it, unfortunately. We're not there. We can't do anything to improve the, kind of your hardware and improve your collagen necessarily. And then you got to rule out like rectoceles, which are kind of outpouchings in your colon into your vagina or the associated areas, because that kind of can hold stool and create outflow obstruction. So, but those are kind of that's kind of where I would start.
That's fabulous. That's so helpful because, this is something that does come up for sure in my practice. I've had people ask about it. I actually had one person who was going to be going somewhere to Canada or something for possible surgery, and so I love some of those ideas, especially something like an abdominal binder, which can also help with people's dysautonomia and at least giving people something that they can think about and consider trying, discuss with their doctors and everything. So that's wonderful. Okay, great. Well, thank you so much. This has been such a great conversation, and I know that all of the listeners are really like taking notes and getting so much information. And I just want to thank you for taking the time. Before we hang off, can you tell us a couple of quick things, well, hopefully relatively quick, where people can find you, what kind of practice you're doing nowadays, and if you can see people from certain states or, kind of how that works. And I think that's it. And if you have any special projects that you want us to know about.
Yeah, thank you for allowing me to give me the platform to say this. So you can find me on Instagram at Dr. Zach Spiritos. We just opened up our new clinic called Ever Better Medicine. I was previously with UNC. Um, and Ever Better is a telehealth clinic that is in North Carolina and Illinois, aimed to treat, we have a weight management division, but also a kind of a dysautonomia, MCAS, chronic complex digestive symptoms division as well. So we do treat POTS, we treat MCAS, we treat all these tricky GI conditions, whether it's gastroparesis, cyclic vomiting syndrome, chronic pseudo obstruction, really, you name it. And we want to make kind of identifying and treating these complex disorders accessible. So you don't have
Mm.
to go to Mayo, you don't have to go to Cleveland Clinic or these amazing motility centers. Like we can come to you, you can be in your PJs, and we can work through this together. It is a hand-holding operation. It is not a set it and forget it. I will never put you on anything and say, see you in 6 months. We are working together. It is a partnership. We have an amazing dietitian. We partner with GI psychologists. We're going to hire a pelvic floor physical therapist. We're creating exercise plans for core and lower extremity for people with dysautonomia. So we're trying to create this kind of network of individuals to really support these folks who are misunderstood, whose symptoms are minimized, and try to get them better quality of life. So it's a partnership, and I'm really excited to get going. And we're starting to see our first patients in the next couple of weeks. If we are not in your states, please send me a message about where you want us to expand to, because we are going to expand over time. But we got to crawl before we can walk, and we got to make sure our EMR works and our website works first. But
Yeah.
we're excited
Yeah.
to get out there.
Yeah, the whole state licensure thing is such a nuisance. So right now you can see people from North Carolina and what did you say, Illinois?
Illinois. Yeah.
Okay, okay. Very good. So if people are in different states, like you said, reach out to you on Instagram and say, "Hey, think about getting a licensure in Colorado so I can send you all my Colorado patients."
Yeah, we're super receptive to that. And you don't have to be a resident of either of these states. You just have to be, if you want to take, a vacation in Wilmington or Chicago, we can see
Oh,
you while you're there.
I see. I see. So they have to be sitting in that state when they have the tele appointment with you.
Exactly.
Okay. Okay. Very good. Well, thank you so much again for taking time out of your very busy schedule to chat with me and share some really great clinical pearls that people can walk away with. So thank you.
My pleasure. Thanks for having me.
So I'm so grateful to Dr. Spiritos for coming on the show today and talking about gastrointestinal concerns that people have with EDS, dysautonomia, and mast cell activation. We know that this is so common, and I know so many of you are suffering from these symptoms. I'm excited that he's opened his clinic, and I know that he doesn't currently accept insurance, but he's hoping to in the future. So just wanted to give you a heads up about that. And I also want to thank you for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex conditions. If you would like to dig deeper, you can meet with me one-on-one. Check out the available options on the services page of my website at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at hypermobilitymd. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can find full video episodes up every week on YouTube at Bendy Bodies Podcast. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.